Hello, good evening, everyone. Prof, we are waiting for you to share your slide, please, sir.
You gave two, three different links, so I'm trying to. Well, can you share it from your own end? Yes.
Okay, let's try and share from our own end, sir.
I'm still trying to open the Google one. The WhatsApp one didn't open. That's the one I have on my laptop now.
Okay, Prof, we are trying to share your slide. Welcome, everyone. Let's just take a few minutes and share slide, please. Prof, we've shared the slide. Would you want to start?
Okay.
Okay.
Well,
So we'll be controlling we're set. We'll be controlling the slide for you.
Okay. Now I'm trying to. If I can have it on my laptop.
Do you want us to give you a few minutes?
I just said 2, 3 minutes.
All right, sir.
All right. I think you are not able to share, but you'll be changing it for me. Can I have the next slide? Am I being heard at all?
Yes,
Hello?
sir. If you are ready, then we have to do introduction so that you can start, sir.
Okay, go ahead. Go ahead.
Okay, good evening, everyone. We are sorry for the little delay we just experienced, technical difficulties. I want to thank us for joining today's meeting. And in our midst is a professor of medicine and a consultant cardiologist. We are privileged to have Prof in our midst to speak to us today. So I want us to relax and learn from an erudite scholar. So today we'll be looking at a topic, cardiac failure, or you can also call it heart failure. This is to help us be knowledgeable about patients in this condition and what best to do for them in terms of management. So thank you everyone for coming on board. So Prof, the floor is yours. Our ICT lead will be changing your slide for you, sir. Thank you.
Right.
You can start speaking.
Sure. Yeah, thank you very much, physiotherapist Wosu, for this. I'm pleased to be here. This is not the first time I've had opportunity to interact with the individuals in this very noble profession. And in the next few minutes, we're going to talk about an issue that is very important. We're going to talk about heart failure. Heart failure is something that happens to a significant number of the patients that we are there to serve. So it's good. In the next 20, 25 minutes, we're going to learn a few things. Then I always prefer interactive sessions, and we'll have at least 10, 15 minutes or more to have interaction. This is how we're going to deliver the lecture, starting from definition, what is heart failure, and then classification and the rest that you can see on the screen. Next slide, please. Definition of heart failure is defined as a chronic and progressive condition where the heart muscle is unable to pump enough blood through the body to meet the body's need for blood and oxygen. The last session we had, a session like this we had last year, we talked extensively on cardiac anatomy and physiology. We talked about the pumping of blood. I'm sure even those that did not attend had access to that slide. I imagine that people should have spent a few minutes to go through it before this lecture, which is also related to that one. So I'm not going to talk about that. Next slide. So, well, the definition you had about, I say, chronic situation, but sometimes, a few occasions, it can happen as acute, as you can see here in number 3. It can happen acutely in some cases, but these are, it could be systolic. You know, the heart has systolic function, pumping blood to the entire body, and diastolic, receiving blood back into the heart so that they can oxygenate it and then pump it out again. So it can be the systolic heart failure, the systolic function that fails. It can be diastolic if the heart is unable to receive blood from the body during diastole, then it's not going to function properly. Chronic, we have already mentioned. It can be left-sided. Really, heart failure is talking about the left ventricle, for instance, and the left atrium failing, or it can be right-sided heart failure. Next one. Well, the common causes, we put hypertension. If you got this slide from US or UK or any of the developed countries, hypertension wouldn't be number on the top. But in our environment, among blacks generally, hypertension is uppermost as the cause. Atherosclerosis, that is thickening of the arteries, or when you have atheromas lining the internal part of the arteries, can cause that. Arrhythmias, disturbances in rhythm of the heart. Some people choose to call it dysrhythmia. I even prefer dysrhythmia. Arrhythmia means absence of rhythm. You may have rhythm, but it's abnormal. The myocardial infarction, in developed countries, this probably be higher up than where it is put in this place. Obesity has a lot of problems with it. It's better people whose BMI are more than 28, 29, body mass index, should try and control it. It's not too difficult to control. Then excessive alcohol intake is there. Then tobacco use. Tobacco has no benefit at all. So we say stop smoking. Then in terms of clinical manifestations, the symptoms, what the patient complains, fatigue. They tell you easy, I get tired easily for no reason. The person doesn't initially know the reason for that. They feel weak. Then they have shortness of breath. It starts with exertion, but with time, when it gets worse, when it progresses, it be at rest. The patient is sitting down and has shortness of breath. Then it comes with cough and wheezing at a stage. Anorexia, unable, they don't feel fine, they're not feeling hungry, they're not feel like eating at all. Paroxysmal nocturnal dyspnea. In the night, when they lie down flat on the bed, they cannot. So we advise them to use 2 or 3 or more pillows in the night. And then, of course, nausea, they feel like throwing up, abdominal pain will be there. And then nocturia, they keep urinating in the. And to add to that, as we're going to talk later, some of them are giving diuretics that cause people to urinate as part of the treatment. In terms of signs, when the patient is examined, if they have pulmonary edema, the lungs are congested, they're unable to. And from that congestion, they have pleural effusion, fluid inside the lungs, inside the chest, which is not comfortable at all. They have their heart rate increases. The heart is trying to pump faster to meet up with the supply. Then narrow pulse pressure, the difference between systole and diastole gets narrow. Of course, as we're going to mention in terms of investigations, there'll be evidence of enlargement of the heart, cardiomegaly. Then when you examine them, even on examination, you will see evidence of cardiomegaly. Then you have peripheral edema. The legs are usually swollen. Sometimes it gets beyond the knees in terms of swelling. It starts with the lower part of the feet, and then it goes up. Starts from the ankle. From ankle edema, it goes up. So when you look at the neck, you will see the vein. Usually you don't see the jugular veins. But somebody who is in heart failure, you see the jugular veins. Next, please. Then in terms of investigations, I put echocardiography here because it is, some years ago, we're not putting it because it wasn't available in many institutions. So now it's becoming more available in most standard hospitals. So it's the best way of making the diagnosis. Then electrocardiogram, ECG, why I didn't put it number 1, that it could be normal in somebody who has heart failure for one reason or the other. So you can, but some may show typical abnormalities. A good number will show what we call ST-T wave changes. The ST-T wave is supposed to be upright, but in these people, it goes inverted, becomes inverted, and with the ST segment as well. Serum creatinine, it affects the kidneys. Increase because it's due to hypoperfusion. The kidneys are not receiving enough blood, just like the rest of the body. Then the complete blood count is also useful in determining heart failure. It's due to the reduced oxygen carrying capacity. It affects the complete blood count. Chest X-ray is very crucial in detecting cardiac enlargement. We see the heart is enlarged beyond what is expected. And then X-ray will also show the pulmonary edema pleural efficiently and guide those who are supposed to intervene. The electrolytes, urea and creatinine will show hyponatremia. In that, sodium gets low and associated with reduced survival, indicating worsening volume overload and or disease progression. Next one, please. Well, this is the pathophysiology. We talked about the physiology. Pathophysiology is abnormalities. We talked about it last year that we had a session like this. So left ventricular failure, right ventricular failure. And they all get, the body tries to compensate somehow, but sometimes that compensation fails. And part of the compensation is like increasing the heart rate, and then and eventually it doesn't work. It gets worse. When it gets worse, they get congestive heart failure. And then what the effect it will have is increasing the cardiac workload. The cells are being overstretched. Then you have compensatory hypertrophy of the ventricles. Next one, please. Next slide, please. I wish I was there. So for diagnosis, to make diagnosis, well, echocardiography here is actually supposed to be the number one. But let's start with electrocardiogram, ECG is more readily available. That's why in this type of thing, normally it's put as number one because it's available even in smaller hospitals. Small private hospitals, a good number of people have that. So it's more readily available. Then chest X-ray, we already talked about the findings. Echocardiography, what makes it most very important is that it shows you the heart, shows the size, it shows the measurements of the chambers of the heart. And some people may need heart catheterization. It's available at the University of Nigeria Teaching Hospital. I said that for some time. I think it has some problem. They're trying to sort it out. The catheterization, you do angiography. Coronary angiography will show you whether it is from ischemic heart disease that is causing the heart failure. Then blood tests we already mentioned are also crucial. Next one. Where the treatment, we start with non-pharmacological management, non-drug treatment, bed rest. Of course, they don't even have any option than to rest. But for anybody who doesn't understand, they say, please, you have to rest. But many of them are forced by the symptoms to rest. Then they shouldn't take heavy meals because the heart is not pumping normally. They cannot be able to. So it's better to take small but frequent meals to make up for the small quantity. Moderate sodium restriction. You have to restrict sodium as opposed to people who come with hypertension without any evidence of heart failure. You tell them to restrict their sodium. But in this case, moderate sodium restriction is applied to this. Smoking cessation, it says smoking cessation. Well, here we have avoid alcohol intake. We don't normally take a little alcohol, but if somebody already has developed this, it has the disease, I think it's advisable for the person to stop for that period. Then the treatment, the drug treatment, these are the list of drugs, which I'll quickly go through them. Then I'm sure the slides will be available to everybody. You will look at them later. The drugs that we normally use, AC inhibitors, and we're going to mention them. Diuretics, I should even have put diuretics first because these are the ones that give immediate response to the patient. Inotropic agents like the digoxin and other very important. Beta blockers, calcium channel blockers, vasodilators, digitalis. Well, digitalis is inotropic. So they should have put it again. Aldosterone antagonists, but they're on diuretics, especially furosemide. So they need aldosterone antagonists, prolactin and others, because the loop diuretics like furosemide normally reduce the serum potassium, which is very dangerous. So they need prolactin to restore the potassium as much as possible. Then angiotensin receptor blockers. Next one, please. So the diuretics next. Thiazides are the commonest used, especially for those who start with hypertension. See, hypertension is the most common cause. A good number of them would actually have been on hydrochlorothiazide. And hydrochlorothiazide, thiazides have been found to be very effective, diuretics generally, particularly in blacks. They are quite more effective in blacks than in the Caucasians. So the most common here is hydrochlorothiazide, but you have metolazone, you have chlorthalidone. Block sodium reabsorption in the cortical diluting segment and the terminal portion of the loop of Henle, and the proximal portion of the distal convoluted tubules. Thiazides these are the functions of thiazides. Thiazides are ineffective when the glomerular filtration rate falls below 30, 40. You know, expect it to be 80, more than 80 or 90. In fact, the normal expected level is greater than 90 for GFR. But when it's as low as 30 to 40, then the thiazides are usually not effective until it improves. Decrease preload and improve ventricular efficiency by reducing circulating volume. Remove peripheral edema and pulmonary congestion. That's the function of thiazides. The hypokalemia, you have hearing loss, hypercalcemia, and depletion can result from it if you use it for a long time. Your thiazides reduce potassium, but not as much as the loop diuretics we're going to talk about. Next, please. The loop diuretics, you call them because they work in the loop of Henle in the kidney. If you remember, everybody here, I'm sure, did anatomy. If you remember that, the anatomy of the kidney, that's where they work. They call them loop diuretics. They're very, they cause diuresis more than the thiazides and the other ones. Furosemide, well, Americans call it furosemide. Everybody is imitating them, but British call it furosemide, but it's the same, whichever way you. But I think we're British, so I always prefer British spellings. Bumetamide, tosimide. People are beginning to prefer tosimide. It's a personal thing, but I choose furosemide more often. They are rapid in onset, relative short duration of action. That's an advantage. So that a patient, once he takes it, I normally tell my patients, if they have to take it 2 times a day because of their condition, I tell them, don't take it after 4 p.m. so it doesn't disturb your sleep. 2 or more doses are preferable to a single large dose. They inhibit chloride absorption, the ascending limb of loop of Henle, which I mentioned earlier. Increases systemic venous capacitance and produce rapid symptomatic relief. The side effects you can get is hypokalemia, I mentioned, alkalosis. Hypokalemia, you counteract it by giving spironolactone. We're going to mention that. Next one. Potassium-sparing diuretics. Spironolactone, mentioned that. Trimethoprim, amiloride. But the commonest and the most available is spironolactone. It's a specific inhibitor of aldosterone. And the reason it is very important, it spares potassium. So when a patient has to be on loop diuretic like furosemide, they should be on spironolactone as well. It's a diuretic as well, but it's not as effective as a diuretic as a furosemide. Next one, please. Next. Well, they are inhibitors of the renin-angiotensin-aldosterone system. I can't remember whether we mentioned this during the lecture on these are captopril, enalapril. I'm sure everybody should have had all this. Enalapril used to be very common. Captopril is not very commonly available here. Even lisinopril is not available around. They inhibit angiotensin converting enzyme, and they cause feedback increase in renin releasing. That's the physiology that we're talking about. So the side effects they have: hypotension, renal insufficiency, dizziness, lightheadedness, blood vision, syncope, low sodium hyponatremia, hypovolemia, reduction in volume of the blood. Then they can cause dry cough, but up to 30%. And the cough is usually horrible. That 30% that have it, some people go as far as having angioedema. They have swollen lips and all that. But it's in 30% of people who take it. Once they do that, you stop give them alternatives. And it's contraindicated during 2nd and 3rd trimester of pregnancy due to increased risk of fetal renal failure. So you shouldn't be given in pregnancy. Next one. Next slide, please. Sorry, I wish I was sorry to. Then the angiotensin receptor blockers. Losartan, candesartan, telmisartan, which is not good. Telmisartan is becoming quite common now. These drugs, they inhibit the binding of angiotensin 2. So thus they preclude the above mentioned effects on angiotensin. Well, they are very useful and they're very commonly used as well. Candesatan, well, they take time and look at this. Candesatan normally start 4 to 8 milligrams. Valsartan is very common, it's one of the commonest. You use up to 40 milligrams. Some people on 80 milligrams. Some even on 160, very few. Next one, please. Next slide. The inotropes are very important. Inotropes are like the digoxin. Digitalis is the official name. It increases force of contraction. And they all increase intracellular cardiac calcium ion concentration. Digitalis, dobutamine, ambrinon. Ambrinon is not very commonly used, but digoxin is readily available in the environment. Next one, please. Digoxin, that is available. That's why we're pointing it out now. Inhibits the sodium-potassium ATPase pump. Functions in the exchange of sodium and potassium ions. Well, these are just the functions. And it enhances it enhances cholinergic activity, which reduces heart rate. Due to this, time required for the diastolic filling gets enhanced while the myocardial oxygen consumption is restarted. So this digoxin is very important. Next one, please. Next one. Well, the problems you may encounter with that is bradycardia. It reduces the heart rate. So you have to be very careful, especially in the elderly. People over 60, 70 years, you don't one tablet is 0.25. Somebody who is 60 or 70 years, you normally give them 0.125 milligram, half of normal dose, and it's usually effective. They may have nausea, vomiting, visual disturbances, non-paroxysmal junctional tachycardia, supraventricular tachycardia, and then the sexual dysfunction is there. Well, a good number of it, especially the diuretics as well, cause that sexual dysfunction. Next one, please. Well, other ones, dopamine, dobutamine, can use if the digoxin is not. They more commonly use these ones in the UK and some advanced countries. But here we don't have much problem with digoxin. And digoxin is relatively much cheaper than those ones. So they are effectively used in our environment. Next one. Next. Well, the alpha blockers, no, beta 1 blockers, bisoprolol, carvedilol, metoprolol, they are very useful. But heart failure is accompanied by increased activation of sympathetic nervous system. So that is why these beta blockers that inhibit the sympathetic outflow, they are very, very useful. You know, before, many years ago, when I was in medical school, if you said you were going to give a beta blocker to a patient in heart failure, you failed that exam. So these are the new things that have come up in the past few decades about use. So now people who are in heart failure are given, but it starts with a small dose because they have negative inotropic effect. I'm sure they're going to mention that. So if you give normal dose from the beginning, they worsen the heart failure symptoms we mentioned earlier. So you normally start, the bisoprolol comes like 5 milligrams, but you start with 2.5. Then later on, when they start to improve, the heart function improves, you can increase to 5 milligrams. You may also have to monitor the heart rate, the pulse rate, because they cause bradycardia. Especially if the patient is taking the digoxin and taking it, you need to monitor that and then adjust the doses. Next one. Next slide. The vasodilators are used. They are more commonly used in the Caucasians where ischemic heart disease is very common. Isosorbate dinitrate, And then hydralazine is also available here. All the azosobide is also available. They relax directly the arterioles and the arteries, reducing the peripheral vascular resistance. They also help to reduce afterload, increasing the volume of blood that is being pumped out. That's what afterload is all about. But you can get nausea, palpitations, tachycardia, and then salt and water retention, or if they're going to use them for a long time. Next slide. Well, this you can take time and look at this. It's something that you can look at, talking about the pattern, what happens when you are giving these medications. So just take time and look at that. It's highly informative. That's increasing. Next one. So this was nitrates. This one concerns the nitrates as well, how they function, what they do for nitrates, and then resulting in the vasodilation. That's how to result in the vasodilation for them to be called vasodilators. Next one. Next slide, please. The calcium channel blockers, all of us know, nifedipine, verapamil, diazam, they're all amlodipine. They didn't mention amlodipine is one of them. They block the calcium channel and prevent the entry of calcium to the cells, which is very important with people who have, especially those who have high blood pressure, which in an environment happens to be the most common cause of heart failure. Next one, please. Well, aldosterone we've mentioned, that's why I'll mention it now. It's very important. Spironolactone is a common one that is used, and we've mentioned what it normally does, especially its effect in minimizing potassium loss. Patients have hypokalemia. Usually people who have heart failure have hypokalemia. They don't start giving them diuretic, it tends to worsen it. So you shouldn't give them torsemide or furosemide without giving spironolactone. Next slide. Next slide. Next slide, please. Okay, this is another one that you need to take time and look at. Those are high risk of heart failure, structural stage B. Stage D is those who have refractory heart failure. Tried a lot of things. Sometimes some people may need cardioversion. They may use the electrical intervention, for the treatment. But stage A, those who are just at high risk, they're not too difficult. Like patient with hypertension, for instance, arteriosclerosis, diabetes, obesity, family history of that. They usually do well if you catch them early. Then stage B, they've started developing structural heart disease, but without sign or symptom of heart failure yet. They also have good outcome. And then those people, beta blockers is also very, very important. You are free to even start with a standard dose because they're not in heart failure at that time yet. The same thing for stage C, structural heart disease with prior or symptoms. They've started developing the symptoms, but here, stage D is that it's refractory. They've already known they have heart failure, but the treatment doesn't appear to be working. Next one, please. Next slide, please. All right, thank you very much. And most importantly, I know you are going to have these slides to have a look. And you can always contact me through our coordinator or chairperson today. And so she can reach me at any time. Thank you very much. Hello.
Okay, thank you, Prof. Can we appreciate Prof with any emoji of our choice? Thank you, sir. At this point, we're going to entertain questions and contribution. Maybe I will start first because someone sent in something to me and said that she won't be available during this discussion, but that she will want to know what are the major things we watch out as physiotherapists when we are putting a patient with cardiac failure through exercise, because we know that even when one is into cardiac failure, the person will still breathe, the person will still eat, the person is expected maybe to stand up at some point and get cleaned up. So is it wise to not to engage them in exercise? And if it is okay to engage them in exercise, what are the precautions we should take when we are managing such patients? So, Prof, if you take these questions, then we'll now give room for others to ask questions. Thank you, sir.
Yeah, thank you very much. It's a very good question concerning, especially with the profession that we're talking about, most people here belong to. But you need to be careful. Even with an apparently normal person, you need to be careful about the tolerance, exercise tolerance of the individual. But when you know somebody has heart failure, you need to be very, very careful. You have 6-minute walk or something like that. The person stops when he's tired, isn't it? It's a form of exercise test.
Yes, yes.
The person stops when he's tired, but you should never force. Because even somebody that wasn't in heart failure, I think you don't force any patient to do an exercise beyond the person's capability. So for heart failure, you see how much the patient can do. Don't try to. As the patient is improving, then you can introduce other aspects of the exercise. I don't know whether that answers that.
Yes, it does, sir. Thank you. Do we
Thank
have
you very
anyone
much.
that wants to ask questions? Dayo, you can also check the chat box whether we have questions then.
Prof, good evening, sir.
I can't see the name.
Okay. Okay, my name
Yes.
is Dayo.
Yeah, Emmanuel.
My name is
No,
Dayo.
sorry, it's not.
So I want to know, at what point do you, as a medical doctor and as a consultant of, as a cardiologist, at what point do you invite a physiotherapist to come manage a patient with heart failure? And my second question is directed to PT Ezinewonsu, who is also ICU physiotherapist. So what is the proper positioning for a cardiac heart failure patient? What is the proper positioning? How do you position the patient? One, and then number two, when you actually say you actually said we have types of heart failure. We have where you mentioned the systolic and then also have diastolic. So what is the implication? What do you look at when someone is having a systolic, and what do you see when someone is actually having the diastolic? And then what are the side effects of these drugs? What are the side effects of these drugs, and then why do you prefer one to the other? Thank you, sir.
Okay, let me start with the last one. I mentioned all that. Maybe when you go through the slides again, I mentioned the systolic. Systolic heart failure is failure of the pump action. They usually present earlier than diastolic, those who have diastolic heart failure. The treatment is slightly different. When the blood is not being pumped properly, then those who need loop diuretics early enough. They're also likely to need inotropic agents that we mentioned earlier. Diastolic, if you guide them early, you start with beta blockers, bisoprolol and all that. It makes the heart muscles to relax more. Because diastolic failure means that the heart is not relaxing enough to receive blood into the chambers. So you start with that before you go. If you try and guide them early, when people start complaining, it's good to be able to do ECG and do echocardiography at the same time. The heart failure one, no, sorry, the one you asked about, what was it? The first question. The first part of your question. Okay, yeah,
You said
people with
at
heart.
what? Okay, you said at what point do you invite a physiotherapist to co-manage with a
Well, I
cardiologist
think,
when the patient is going through heart failure?
yeah, he also mentioned that you should answer this as well. And I think you're in the right position because we have co-managed patients, even those who had open heart surgery together. There are like people who had terrible, you have to stop the heart, operate on it, and then start it again. It's almost like heart failure. And she has co-managed so many. We did nearly 300 open heart surgery. And everybody, from as soon as the patient leaves the theater, the physiotherapists come into it. They're all part of the team. That is why I believe in teamwork. And you cannot even talk about the heart, especially open heart surgery and all that, without the physiotherapists. I tell people, if the physiotherapist is not there, the patient will not even start breathing normally again. So she has had that other experience. PT also, can you add something to that?
Okay, what I want, Prof, I think you have said it all. Once a patient is admitted in the ward, the patient we usually get a referral to come and see the patient so that we can start on time to maximize whatever capacity the patient has. So when we get a patient with heart failure, we usually do 6 minutes walk tests to find out the exercise tolerance and capacity of that patient. Then we can now prescribe exercise based on assessments. Then when they now go for surgery, we see them pre-operatively and post-operatively after the surgery. So I think a physiotherapy involvement in patient with cardiac failure start quite on time, especially once the physiotherapy team and the cardiology team are willing to give the patient the best. Then in terms of positioning, we usually keep patient with cardiac failure in cardiac position so that the lung can breathe better and whatever that is remaining of the heart can also, get to the body. So now putting a patient in supine will not help the patient at all. So it has been found out that cardiac position, which is lying down like 45-degree head up on a bed, benefits the heart more. Thank you.
Yeah, thank you very much. I'm happy you mentioned this. When I said non-pharmacological treatment, this positioning should have been mentioned there. Please, you should insert it. No, the positioning is very important. The cardiac position, 45, inclining 45 degrees. In fact, when their symptoms start, they say, I can't breathe. Remember, that's one nocturnal dyspnea, because many people lie with one pillow. Some don't even sleep with pillow. I've seen people who don't even like pillow at all. But not many people would have used 2 or 3 pillows. But somebody in heart failure needs to do that to prop up but otherwise they won't be able to sleep. In the night you'll be choking. And the tendency, what they do is to sit up all night, go to their sitting room and then sit. Thank you very much for mentioning that. I appreciate it.
Okay, do we have more questions? Is there any question on the chat box?
No, no, ma.
Okay, if we don't have any questions, I would like to appreciate us for attending this wonderful meeting. And we have dropped the slides. It is important that we all go through that slide. So we are going to add Prof to our group so that whatever question you still have about cardiac failure, you can drop it in the group chat or you can send to me. We always call his attention to give us an answer or an update to whatever it is that has to do with cardiac failure. So I want to thank Prof for accepting to come on board and give us this lecture. And everyone, I know this is not our usual time. Our usual time usually 7 p.m., but for the peculiarity of our presenter, we have to squeeze in this presentation into 6 p.m. It has been recorded. It will be on our chat box, on our WhatsApp group. So when you have time, please do go through the slide and listen to the presentation and drop your questions or comment. Thank you so much for coming. See you next time. Good night, everyone. Thank you, Prof. God bless you.
Thank you very
Good
much.
night. Thank you, Prof. We really appreciate you.
Prof, that's our HOD talking, you know.
My greetings to the HOD.
Thank you, Prof. Thank you, everyone. Oli, thank you. Thank you for the good job. AB Media, thank you.
Thank you, ma. Good night, everyone.
Good night, everyone.
Good night, everyone.